Hello, my health freedom loving friends. Misty Carlfeld here with Health Freedom Idaho, and I have Sarah Dunn joining us. She's a midwife in Coeur d'Alene, and she's had quite a few interactions with Kootenai Health that I think are important to talk about. Now, I heard her name first from Max, the father that I did an interview with before about his experience with CPS and Kootenai Health. Thought he thinks the world of you, of course. And then I had another interview with Hannah, and again, she was singing your praises. And I want to say I am so thankful for what you're doing, telling the patients about their rights, because I hear over and over and over, if I had just known my rights, I wouldn't have done that. If I just known my rights, I would have left sooner. And so it sounds like you are sort of the voice of reason, the voice of parental rights in Coeur d'Alene. So I really appreciate what you're doing. I thank you for joining me too.
Thank you.
So tell me about your experience with Kootenai Health. How did this all start going, where you saw more interaction with CPS at Kootenai Health and more upset parents, really?
We noticed a huge growth in our community in the last few years. We are, we're over 70% California transplants. A lot of people are coming here from bigger cities looking for, kind of more of a small town deal, or escaping high prices of, housing or whatever. And so we just become a really popular place to live and to move to, which is great, but our medical system has not been able to keep up with the demand. I've definitely seen, as Kootenai Health has grown, administrators getting more involved in care. Whereas before we would just speak with the doctor, well, now we're having the doctor will be involved and the nurses will be involved, but then we also get a visit in the room or, the experience at some point from the charge nurse or the head of nursing or the head of administration or the patient hospital risk management advocate will come in. Sometimes by request because we have an issue and we need clarification, but mainly it feels like this preemptive move. Things are going fine and we get a visit from people who haven't been requested or who aren't really needed at the time, but just in case you need something. And it definitely has felt intimidating to me as a healthcare provider. But then I think our patients have reported that, they feel like, well, how come this is escalated? I'm just here for this. How come I ask a question and all of a sudden hospital administration comes into my room? I'm not upset. I'm not denying care. I'm just asking some questions, and this is suddenly escalated. And now I feel overwhelmed or intimidated. And it's happening more and more often. So about, maybe 4 or 5 years ago, Kootenai Health did a huge multi-million-dollar expansion. And in that expansion, they expanded their maternity services, rebuilt that floor, and then they also added a NICU. And that was important because every time before we would bring the baby in, if they could triage the baby and send them home and say, oh, everything looks good, we did an x-ray or we listened, because sometimes we just need to make sure baby's transitioned okay. And if everything was fine, we would get sent home. If there really truly was a cause for concern, risk of infection, blood work comes back not great, something was happening, we would get sent over either by helicopter or ambulance. We would get sent over about 40 minutes away to Sacred Heart because they were the closest hospital that had a good NICU unit. Mm-hmm. And it was rare that needed to happen. A couple times a year, maybe that would happen once or twice, where we had a baby who was sick or just some extenuating circumstance was going on and we needed to seek that higher level of care. What I've noticed, however, is that as that has happened, they've brought in neonatologists, perinatologists. What I'm finding now, instead of being triaged and sent home when appropriate or back into our care when appropriate, every single one of our babies is being admitted, whether or not there's an issue. When I look at historically 16 years of providing for families, and I know the percentage of babies that I had looked at that were sent off to the NICU at Sacred Heart versus the percentage of babies that are looked at now and immediately admitted and given IV antibiotics right away, regardless. So like their initial blood work comes back. Again, it takes maybe three or so days to culture urine or culture blood to find out, does this baby have an infection? What is the infection and how we're going to treat it? In the meantime, they're wanting to give a broad spectrum antibiotic to these babies so that if they get the culture back, they don't go, well, we just didn't treat a baby for 3 days who's now septic and dies.
Right.
That is a legitimate thing. But they can get initial blood work back within 30 to 60 minutes that will tell them, is there reason for concern? We may not know exactly what we're dealing with, but all roads lead to something. We may not know the exact bacteria, but this initial blood gases, white cell count in the baby is looking like this. We should treat just in case, because it's a pretty good chance that this is going to happen. What I'm seeing is that before you even have an initial blood draw, doctors are saying, here's the deal. We're going to start them on antibiotics right now for the first 3 days. Worst case scenario, you'll be here for 10 days on antibiotics. And parents are going, wait. I appreciate that you're telling me what could happen, but you didn't say, if I get this blood work, we're going to start this. You just said, we're going to start this.
Right.
And the minute that logic kind of hits parents, doctors treat them, I've seen, like they're being non-compliant. And I had a case 3 months ago where same thing. We brought the baby in because she'd had some breathing issues. And the doctor says right off the bat, we haven't even gotten an IV in the baby, no blood draw, nothing. Says to her, okay, well, we're going to put in an IV and start antibiotics. And the mom goes, wait, we came here for breathing to make sure she was breathing. Why are we doing antibiotics? And she said, well, because if we find out later on the baby, and she goes, okay, but is there a way to initially find out if there might be an infection? Maybe you can't find, I get what you're saying about the culture, but do we have any initial information you can gather before you start pumping my baby full of a broad spectrum IV antibiotic hours after birth? And the doctor said, well, yeah, I mean, I guess if you want to wait, it'll take about an hour, but hopefully, the baby's okay. And the baby was totally, vitals were fine, everything pink, nursing, the baby's great. So the initial blood work comes back after an hour, and sure enough, it looked great. So the doctor comes in, you could tell she wasn't very happy about it, because she comes in, she goes, well, surprisingly, this blood work actually looks pretty good, but I would still recommend starting the antibiotics because things can just change. And the parents were, they were like, we just had this conversation. Can you, if she at any point, oxygen saturation drops, she stops being responsive, she's not nursing, she's breathing weird, use heart rate, temperature, anything changes, if at any time that changes, could we redraw the labs and see if suddenly they look different? Or could we then talk about antibiotics? But right now, what you're telling me is my child not only visually looks healthy, but by her blood work, she looks fine. And you still want to start antibiotics. And the doctor talks, and these were pretty educated parents, the doctor talks so much about death and whatever, that they ended up choosing to do the antibiotics that day. And I was there for the whole conversation. I didn't give medical advice. I didn't even give my opinion. I was just there transferring care. And I'm always able to be in the room when we transfer a baby. This was the first time ever that about 20 minutes after we were there, they said, so here's the deal. We have policy that providers can't be in here, so you're going to actually have to leave. We let you be here while we had this initial discussion, but you're going to have to go. Even a month prior, I've been able to stay the night with a patient. I've been able to be there at all hours, visit as much as I want.
Well, it's this ever-changing policy.
It's ever-changing policy, and it's clearly escalating. They clearly see outside support as a threat. And I wasn't even speaking. I was just there. But the thing is, they can't convince the patients of anything if I'm standing there. It's accountability. Right. It's accountability. And the whole time this is happening, I'm looking at the nurses who are just keeping their head down. They are getting, it feels really weird. So
did they ever give those parents the risks involved with the antibiotic?
No, and they brought him up. They said, well, we're worried about this or that. And she was like, well, you're looking at she said, well, the doctor, first of all, gave misinformation. She said, well, that doesn't happen. Yes, it does. We know about the gut biome. We know, to this day, the baby is 3 months old to this day, or 4 months old. To this day, she is no longer breastfeeding. She had so many gut issues. developed yeast. I mean, mom battled with all of this digestive stuff. The poor baby was miserable. And it's hard not to think it had to do with getting that level of antibiotics. By the way, the cultures came back, were totally fine.
Oh my
Baby
God.
never dropped in stats. They went home 2 days later. Everything looked good. Mom was right. There wasn't a reason to be there. And I know that occasionally, you know, I guess it could have gone the other way, but there was never a point where anything indicated that that kind of treatment was needed, was appropriate, was standard of care. The only reason that baby was given antibiotics and the parents consented is because they heard so many scary stories from the doctor. And the frustration with that is that we understand that they want to give appropriate health care and that sometimes you can't see an infection right away. We have to get cultures back, which take 2 to 3 days. And in the meantime, if you leave a condition untreated, babies could get really sick. And that's understandable. Sometimes you treat, it's a shot in the dark, and you're hoping you don't need it, but you don't want to be so behind that you have a really, really sick baby when you get those results. Understood. But what I'm seeing more and more is that it's not just information being given to our patients. It's, for me, scare tactics, or they're giving worst case scenario right away. It should be really important. The goal should be not just that babies are taken care of and that patients are healthy, but the goal should be like, how do you teach parents to make informed decisions? How do you teach them to have those hard conversations and still feel that they are respected as the primary decision makers for their children, and at the same time address why are these healthcare professionals concerned? A lot of these parents aren't doctors, they aren't nurses, they haven't gone to school, they don't know how to read blood work or test results, and that's fine. But just because they don't know those things doesn't mean that their opinion doesn't matter.
No, that's what we rely on the doctors for, to explain it to us, tell us the pros and cons, right? That's why we're there, for their expertise. Right.
And I can say I've never, there are situations with my own patients where I have to say, hey, things have kind of shifted. There's a situation where I have to let people know this is kind of what I'm thinking. Here are our choices right now. But in a true emergency situation where I know, hey, this needs to be taken care of, I've developed such relationships with my patients that they don't necessarily argue with me, not because I've scared or intimidated them, or I've never threatened to call CPS. I've never had to threaten to call CPS, because our communication is such that we have that trusted relationship. And they know if I'm saying something, they know that they can believe it. They know that it's evidence-based. That's the kind of care I've always given them, and I don't have an ulterior motive. And that relationship doesn't necessarily exist within the system. Parents either don't know that they have a right, they don't know that they can say no, they don't know that by signing in, I'm consenting to care, that they can still ask questions or stop at any moment or get a second opinion or, ask for more explanation. A lot of parents just defer to the system because they either don't know that they can ask a question, or they don't know what questions to ask, or they're so afraid for their baby and what's happening that they do want someone else to make the decision. And that's fine. However type of parent you are is fine. If you want to defer to the medical system and just say, hey, take care of it because I'm overwhelmed, that's okay. It's also okay to say, I'm going to go ahead and seek treatment here, but I'm going to still stay in the driver's seat. And I want you to be along with me for this ride, not take over the wheel and throw me in the back seat. That's not okay for me. And I, as a healthcare practitioner, I don't want a patient who's just going to do what I say. I want them, that makes me nervous. I want somebody who agrees with that, or they also, think that that's the decision that needs to be made. And if we're not on the same page, then we need to talk more, or I just need to respect that that's the choice that you make. So that collaborative care that they're used to with us, where we are giving evidence-based, care or information, and then they are making an informed decision, and then we are supporting that informed decision, that's what they're used to. And then when they go into another system where that is not necessarily the dynamic, it's shocking for them. It's frustrating. they're now dealing not only with the reason why they're there, concern for their baby or their child, but now they're dealing with this feeling that they're in a system that doesn't support them as parents, that doesn't support their decision, and that is threatening outright. Up until probably 3-4 years ago, I can say in the 16 years, I've never had a patient who had CPS called on them, ever, by the hospital, ever. Now, it's happening all the time. And if it isn't happening, the threat is there to happen. So the minute a patient says, well, hey, why are you doing this? Or what are my options? Or what if I don't do that? The answer is consistently coming back, well, if you don't do that, it's our obligation to call Child Protective Services. Which, when that happens, no longer does the decision for the parent become about evidence-based care or informed consent. It becomes about, do I or don't I want to put myself in the position where I may or may not lose my child?
Right.
Child Protective Services is there to protect children. That we hope is the intention, for situations where there is abuse, neglect, abandonment. We want a system that is there to advocate for the child, for sure. It's determining whether or not there's even basis for concern that becomes the problem.
Right.
Because I've watched those guidelines really become more and more narrow, and the threat of that is used, I dare say, coercion, often, where it's scary, and people aren't making choices based on logic or blood work or, again, evidence. They're making it based on fear and threats.
So when you have asked the hospital administration, these folks that you're having to deal with now, when you've asked them for the policy, what do they have a policy on when they call CPS? Do the parents understand the policy when they walk in?
I can't speak to for sure what parents think or don't think. I can only speak to what I've been told. I have many times asked or directed patients to ask. I've learned that if I ask, it's probably not going to go well. Right. But I'll always let patients know, talk to your charge nurse, ask for hospital advocacy. If you're having an issue and you don't feel like you're getting information, you always have somebody else you can go to. Ask. The problem is that there's been a lot of contradictory information given. There's been policies quoted and stated, but that haven't been provided. There's been policies that contradict other policies. There's been information that's been given that is, one nurse will say one thing, another nurse will say another thing. And when we say, well, wait, which is it? Then we're really treated as, that we're being combative, when really we're just seeking, what is the expectation? Just be really clear. Yeah. When a patient of mine is told, hey, you need to do this, or it might escalate, well, what does that look like?
Yeah.
What do you mean by that? Oh, we might have to call Child Protective Services. Wait, based on what? Well, you're not doing this. So I'm not saying I'm not going to do that. I'm just asking, why do you want to do that?
Right.
For example, one of the issues that came up with a patient, I had a patient who was interviewed by CPS. Child Protective Services were called because she was a transfer of care. They hadn't seen her before. And they deemed that it was important for a reason. They didn't want her to be breastfeeding the baby. They doubted her compliance, even though she'd been totally compliant. So they called Child Protective Services, and she called me and said, hey, I'm being interviewed. Can you come in and be with me? She had a C-section. She was on pain medication. She was sleep deprived. She wanted to make sure she had somebody, not necessarily to speak for her, but just to be a second pair of ears. I don't even go to the doctor without my husband with me, because it's always a good idea to have a second person there who can kind of remind you and whatever. And I said, sure, I'm not getting paid to be there. It's over a holiday. I leave my family to come in, and I'm happy to do that. And when I showed up to the hospital administration said, you can't be in this meeting. And I said, well, why not? Well, it's our policy that if CPS comes to interview a patient, you can't be in here. And even the CPS worker said, that's not true. She can have 10 advocates in here if she wants. That's not true. And the patient advocate for the hospital said, yeah, that's not true. It was a hospital administrator who was trying to clear the room. And so we have the meeting. Well, during the meeting, I decided to go ahead and record the conversation at the patient's request. She had been given a lot of different information about her baby's care, about CPS involvement, what she should expect when she gets home. And we were going to be talking about all of this stuff during this meeting. She knew that. And so she said, hey, can you either write it down or record it? And I didn't have anything with me to write it down. And I said, yeah, I'll record it. So in Idaho, for those that don't know, we're a one-party state for consent. So that means that in some states, you know, if I were to have this conversation and record it with you, I would have to say, hey, I'm going to record. Is that okay? You'd have to agree to it. Well, Idaho's a one-party state. So as long as one of us knows it's being recorded, it's fine. Somebody else couldn't record our private conversation without one of us consenting, but that's the law in Idaho. So knowing it's a one-party state and knowing that it's totally normal to record a CPS question, I openly had my phone out on my lap in the room recording the conversation. And about 15 minutes into it, the hospital administrator next to me looked down and noticed that my phone was recording again. I didn't have it hidden at all. And she said, stop, everybody stop. Sarah, are you recording this? And I said, yeah. And she said, you can't do that. And I asked, why not? And she said, I don't give consent to that. And I said, okay. And she said, you have to have everybody's consent. And I said, well, I don't. I mean, with all due respect, I'm not doing this to be threatening, but I really just don't have to. It's a one-party state. And so then she asked the CPS worker there, do you consent to being recorded? And he said, first of all, yes, I do. I think that's actually a really good idea because she is fresh out of surgery and on pain meds and tired. So yeah, I think that's probably going to be helpful for her. But second, Sarah's right. It is a one-party state. I don't have to give consent. Well, the hospital administrator was super frustrated that was the reaction. Obviously, she wasn't anticipating that. So she asked the patient, do you consent to being recorded? And the patient said, I asked her to record it. And in fact, I'm recording it as well. So the hospital administrator left the room, very upset. We continued on with our conversation, which was honestly super pleasant. I felt the whole time the CPS social worker, you could just tell that he was very supportive of the mom. I think he was maybe, and again, without putting words in his mouth, but I think he was maybe a little bit annoyed he was there. He didn't quite understand why he was called. I think he knew why he was called. He just didn't understand why there was this big deal about me being there or being recorded. And he time and time again in that interview kept saying to the patient, you just seem like you're really educated. You seem like a really good mom. I think you're asking good questions. You're clearly a good advocate for your baby. I mean, he just over and over again affirmed that what she was doing or asking or saying was appropriate and a good thing. So anyway, a few minutes later, the hospital administrator comes back in with security, with a male security. I think it might have been two male security guards for the remainder of our meeting. And when they walked in, I mean, it was, you know, all of a sudden the mood changed in the room, and the patient is pumping on a breast pump, trying to get her milk to come in, you know, sitting there topless as we're all having this conversation, doing what she has to do as a mom, complying with CPS at the same time, multitasking as we do. And she said, why are they in here? And she said, well, I think if we're gonna do this, you know, we need to have witnesses. And she said, I don't want some strange men in my room. Can you please leave? Right. And we did have the CPS worker said, yeah, you guys need to go. And the hospital, the patient advocate that was in the room said, yeah, this is unnecessary. And so they ended up leaving, and we finished our conversation. So a couple of days later, hospital administration asked me to come in for a meeting with them. And when I said, well, why? They said, well, we just really want to talk about what happened in this case. It wasn't just this. There were several issues, I think, that had happened over the week or so that this patient was in the hospital with her baby, where the patient had asked questions. She had asked me, hey, what is this level? Or what should I be looking for? Or what is my right? And I would email her or I would text her back the answers to those questions. Because she would ask one nurse, get one answer, ask another, and they get another answer. And she was really having a hard time trusting expecting that the information she was given was correct or legal. And there were enough things that she was researching after they would talk to her that didn't line up with either of those things that she heard, that she would message me. Again, we have a trusted relationship. I'm not giving her medical advice. I'm just educating her as to what her rights are or what levels are or whatever during that time. So she would say often to the nurse, well, I was wondering this. Well, how do you know about that? Well, my midwife said that, she sent me this. She was very open about where she was getting her information from. And again, the information I'm giving her is on the CDC website. It's ACOG. They're all the same informational systems that the nurses and doctors are establishing their care based on. I mean, that is where we get our standard of care. I'm not giving them I'm using the same system that is training the doctors and nurses. So you would think that our information would be the same,
right.
Same standards. So when they don't line up, it is confusing to a patient. Why are you telling me this when that's not true? And so there were a bunch of things throughout that week, throughout this patient's care, that caused some frustration for her and grief for her. Definitely changed her baby's care. Her baby was put in the NICU unnecessarily for 3 days. Completely unnecessary, even according to their standards. And so I was called into a meeting, asked to come in to discuss kind of how that whole thing went. There clearly was some tension and animosity, especially during the CPS interview. And I said, sure, who's going to be there? And the risk management said, well, the head nurse said, it'll be me and it'll be this person from risk management. Great. And I said, can I bring in my husband or somebody so that, I'm not outnumbered and I have also some support? And they said, oh, sure, that's fine. So we show up to the meeting and there's my husband and myself, and there are the two people that I was told that would be there, plus the head of risk management, plus the head of security. A big male security guard is there, which was super unexpected and off-putting to us. And so when I asked, why is security here? It was, clearly for intimidation. So when I said, wait, I thought it was going to be two people from your side, two people from my side, and we were just going to have a casual conversation. What's happening? They said, well, we thought that this would be important, and do you have a problem with security being here? And I said, well, kind of, it's intimidating. And the security guard said, well, I'm not keeping you here. You can leave here at any time. And I said, well, thanks for not keeping me here, but why are you even here? And they said, well, he's here in case things escalate. And I'm like, I've been coming here for 16 years. Have things ever escalated? I've never even raised my voice in this hospital. So it felt a little bit weird. But during that conversation, it did come up. One of their complaints was the fact that I had recorded the conversation. So they said, by the way, we need to talk about this recording of the conversation. That is against our policy. And I said, I didn't know that. I had no idea, because Idaho is a one-party state. I don't know, something as far as like private versus public. I don't know. So I said, well, I know historically that if I've attended a birth, they've allowed us to take pictures, but they don't want us to video. And we've kind of been under the understanding that they don't like us to video in case there is a complication. They don't want there to be proof, or things to be interpreted, or, things taken out of context, which I don't necessarily agree with, but I have heard that that's their policy before. And so we've always just taken pictures if we're there. We haven't recorded. We've never even thought to question whether or not they could tell us that we couldn't record. We've just respected it.
Right.
That's fine. And most patients are like, well, if I can't record it, okay. Or they secretly record it and they don't tell the doctor. They just have like their ways of getting their birth documented. But this is the first time that I had ever recorded a conversation for a patient to reflect on, what to expect in the future, like as a record. Mm-hmm. So I didn't know, maybe I was wrong. So I said, well, I am not here to break policy. They outright said, if you can't respect and adhere to our policy, you won't be allowed to come here, which would be a shame because we want you to be able to be here with your patients. And I said, yeah, me too. And I would never, I'm not a rule breaker. I would never, even if I don't agree with the rule, I don't want to break a rule, because that would mean that my greater goal of being there for my patient couldn't be served. Mm-hmm. So I said, do you have, I will respect that if I can't record. Okay. Can you show me where that is though? And they were very taken aback by the fact that I'd even asked that. And they said, well, it's just in our policy. And I said, okay, well, where is that policy? And the head of risk management said, well, do you not believe me? And I said, well, I don't,
Weird.
even if I believed you, I still have a ton of patients that are I want to tell them when I'm telling them something that it's true.
Right.
And if you tell me something, I tell them something, I'm not going to be that middleman. I want to give, again, evidence-based care, truth, studies, things that are concrete, black and white. This is not an opinion. This is not a preference. This is indisputable information. So if you're telling me that this is the policy and I have a patient in the future who wants to record a conversation, I want to be able to, with confidence, say, actually, that's not allowed, and here's where it says it.
Right.
That is my intention. Not to question you, not to fight with you.
Yeah, and the words in the policy are important, because how are they describing it? What exactly is recording? So that's important to see the policy and the words within it.
Well, and policies protect everyone.
Yes.
It's like a rules of a game. If I'm going to play a game with you, we're going to have a rule book there, because it wouldn't be a game. It wouldn't be a fair game if you could just make up some rules and I can make up some rules. And I mean, really, what is the point of the game? It's not going to be fun for anyone. And probably not going to want to come over and play if that's how I act. So, yeah, I was told, well, it is our policy and we don't have that access. That's not something that we give out to the public. That is something within our system that we have, which I had never heard. I mean, we are, as healthcare practitioners, we have to make our privacy policy public, our billing policy public, our informed consent. I mean, we have so many things that we have to even reveal to our patients how they can complain against us. Like we can't keep anything private, except for other patient records. That's about all we can keep private. And
it doesn't make sense to me that you're expecting people to follow a policy that they can't actually look up and see what the policy is. Right.
So she said, well, you just need to trust us. And that statement came up a lot we had about an hour-long conversation. And you need to trust us, patients need to trust us, you're inhibiting our ability to get patients to trust us. That was mentioned over and over and over again. And the concept of people will trust, in what way?
How do they feel that you are inhibiting the trust of the relationship between the patient and the hospital?
So the direct language was, when you come in and people don't see us as their provider, they see you as their provider. And I was told this by 3 different people within like a 48-hour period. You need to understand that when your patient comes in through our doors, they are no longer your patient, they are our patient, which I don't dispute. I absolutely agree with that. Okay. So I said, I agree. And they laughed. The 3 women laughed. And I said, what? Why are you laughing? And they said, oh, you obviously don't agree with that. And I said, how so? Well, you're always giving information and advice to your clients. And I said, well, I'm not giving advice. I mean, not if it's in here. I mean, I have said multiple times, I can't give you any advice, you're not my patient anymore, but here's where you can find XYZ. Here's where there's this list of recommendations or the ACOG standards or whatever policy. So I asked for examples. Can you give me an example of a time where you feel like I have acted out of my scope, or that I have treated someone as though they're my patient and not yours? They couldn't give me one example. And I said, well, how do I change a behavior that you don't like if you can't tell me even what that behavior is? And so they said, well, it's just an overall feel. We feel like we can't establish trust with our patients because, we'll tell them one thing, but then they'll find out another. And I thought, well, right, that's your problem. Then don't tell them things that are contradictory to the truth. And so it finally kind of got to the point of the conversation where I said, look, if you want to be trusted, then you have to be trustworthy. If you're discovering that your nurses are giving conflicting information, you need to have a staff meeting. If you discover that someone who works for Kootenai Health is giving information that is incorrect or is an outright lie or untruth, then you need to reprimand or correct or educate your staff. That is the problem.
Right. So it sounds to me like I was trying to figure out, what do they feel that you're doing that undermines the trust between the patient and the hospital? So as you're explaining all of this, I feel like what I'm hearing is, when you point patients in the right direction, when you tell parents what their rights are, these are the things that they feel are undermining the trust between the parents and the hospital. Is that?
Yes. And that's what they said. Yes.
That's what they said.
That's what they said.
So it's just wild because
that shouldn't be a threat. That shouldn't be a threat. I said, not only should you be giving this information to the parents,
right?
You should be happy that I'm also giving the information to them. I'm doing your job.
Right.
And
the information should be the same. It shouldn't be contradictory.
Right. Right.
So, if they want to build trust with the parents and the patients, then they should be giving them the truth.
Right. Yes. Correct.
It's just that simple. It's just that simple.
It's just that simple. And this whole CPS threat thing, again, I've never ever seen this happen. I don't currently see it in other hospitals. Mm-hmm. I don't currently see it with other providers. I am only seeing this and again, we're all mandated reporters. I'm not saying no one ever doesn't call CPS. They do. Everyone has a responsibility to make sure that children are not, again, neglected, abandoned, abused. Those are the 3 reasons we call. Kootenai Health's apparent, standards for why they call Child Protective Services and what categories that falls into are just not the same as everybody else's. And it's happening so much. And I have social workers telling me, oh my gosh, we're so overwhelmed with these calls. I have them meeting the patients going, I would do the same thing that you did. I've heard the social worker say to the parent, oh man, well then I would have had CPS called on me. I would have done what you did. I wouldn't have given my baby a spinal tap at that point. I wouldn't have given my baby this. I wouldn't have let them take my baby this. They're agreeing with it. I have nurses who work at Kootenai Health who are telling me privately that they feel so torn because their concern is to give good patient care. And they're hearing this bullying behavior. They're hearing these inconsistencies or outright lies. And there's nothing they could do because they will lose their job. Nobody's asking them their opinion. They're doing exactly what the hospital wants me to do, which is keeping their mouth shut.
Right.
I don't work for the hospital. I'm not going to keep my mouth shut. If I worked for the hospital, I would have already quit. And again, my goal is not to make their job harder. My job is, my responsibility is to that patient, period.
Yeah.
And I would treat them like I would any friend, any other human.
Right.
Here is your right.
I'm trying to figure out to what end. Why are they going to these lengths? What are they trying to achieve? And it seems to me that when they use CPS as the threat, that it increases their profits. If they're telling parents, if you leave and you don't stay another night, we're going to call CPS. Well, now they've made that extra income. When they give spinal taps against what the parents want, then they're increasing their profits, right? So I feel like they're using CPS as an arm to increase their profits.
I think that is very logically part of it. That makes sense. The problem with this kind of care or this animosity or, lack of informed consent, what that's causing, the mistrust that's causing is it's going to affect our overall goal, which should be healthy baby, healthy mom. Right. And when care providers are intimidated and scared to go to the hospital, when patients are, I'll have a patient come in and we'll talk about our transport and I'll say, well, if it's an emergency, we go to Kootenai. Nope, I won't go there. I have to go, well, I can't agree to that because right. that puts me at a liable, if it's an emergency, we have to go there. Right. And that's a real problem for people just because of the reputation. And they're not seeing that the overall, there's no other competition in our city. They are the only hospital. Wow. So people will either go there and continue to not have the care that they deserve, that they pay for, that they should be able to expect, or they're going to put themselves or their children at risk by going further to another hospital where they will have that care. But when time is of the essence, you're going to have bad outcomes. And that's a problem. And that's a problem they need to be looking at. And you don't solve that problem by threatening to call CPS. You solve that problem by taking patient complaints seriously, by listening to other healthcare practitioners, by building those bridges, and by examining what's happening within your own structure and saying, how can we do better?
Right.
How can we do better? Not how can we force people to do what we want, not how can we bully people, how can we intimidate people, how can we increase our profit, it's how can we do better and there's always room for improvement. Right. No system is infallible. There is always room for improvement. And I'm seeing nothing from Kootenai Health with the feedback that our patients and that I personally have given them that shows that they're interested in improving their system. Right. They're interested in being heard, in having the ultimate authority, and in getting that by whatever means they need to do that. And that's terrifying.
It is.
I think that there are people go into healthcare because doctors and nurses, they go into healthcare because they care about people. They really want to help people as a whole. I genuinely believe that that is true. Right. But when you work within a system who that is maybe not their main goal, where profit is an issue, where reputation is an issue, where they have an ulterior motive, it's contradictory to giving good, safe medical care to put the business model above that.
Wow. We're actually trying to affect change. They have a board. You know, the buck stops with the board. So I'm hoping that the board hears these videos, listens to what the parents are saying, listens to what you're saying, and that it will affect change, and they'll provide better care with informed consent without using CPS as the heavy.